So the next topic is remote monitoring. So most of the patients of heart failure will have some features, some signs, some evidence will be there that they are going to develop decompensation. So remote monitoring has a role, and for this, we'll listen from Dr. Ayan Kaur. It's always a pleasure to listen to Ayan Kaur. Dr. Kaur, please.
Good afternoon, sir. Thank you for those warm words of welcome. Respected teachers, distinguished members of the chair, my dear friends and colleagues. Firstly, thank you to the organizers for this opportunity. Since I bring the rear of this session, and I hope to be very brief and hope to keep the sessions on time. So it is interesting that I've been given this topic of remote monitoring and heart failure, which is specifically very dear to me. I don't have any disclosures, and I would like to talk to you about how this really works. So if you look at this picture, which is not very uncommon in the streets of India, is so I akin a heart failure patient to this rickshaw puller out here. Somebody who's already very tormented, he's already has a heavy heart, he finds it very difficult to walk. And when we give this patient heart failure therapy, what we add is we add medicines, then we add lab tests. Then there's loss of work, which means he doesn't get to go to work, which means he's not paid. Worst come worst is that if he ends up having a heart failure hospitalization, that is what really ends up having a huge economic ramification on his day-to-day activity. So overall, it signifies what is known as very poor quality of life. Now, if you really go back to the States, United States of America, so heart failure is probably the most common and expensive reason for preventable hospital stays. It accounts for about 1.1 million hospital stays and contributes to about 11.2 billion as total cost. So the cost is huge when we talk about heart failure. So this is 2017 data to end 2023. I think the cost must have multiplied a lot. Now, if you come back home, we go back to the Trivandrum Heart Failure Registry, and this is one slide that I keep showing everywhere. And this tells you that if patients are on guideline-directed medical therapy, the cumulative mortality is significantly reduced compared to those patients who are on suboptimal guideline therapy. And remember, the other thing that we really need to prevent is a readmission. So look at the numbers of patients who have cumulative mortality as well as no readmissions. And remember, this does not happen just like that. So, in order to improve the overall quality of life in a heart failure patient, we are looking at certain interventions, of which the primary intervention, which really saves a lot of money, is hospitalization. It is the most expensive part of treating heart failure. Of course, reduce polypharmacy, then vaccinations and nutrition. So, vaccination and nutrition is possibly the most economical part of treating heart failure. Polypharmacy is something that we are very good at doing as physicians. We can always reduce this. There's a lot of combination therapy available in India. And of course, thanks to generic medicines, cost is significantly reduced compared to anywhere in the world. Now, what are the strategies to avoid such hospitalizations? We are talking about optimal GDMT, which is prescribed, as we know from the Trivandrum Heart Failure Registry, probably in very low numbers, close to 20 to 25% of the patients only. Nutrition, something that we really don't talk to about our patients. Remember, a patient of coronary artery disease with heart failure is very different from a patient with dilated cardiomyopathy with heart failure, let's say because of sarcoidosis or from some other disease. Early recognition of warning signals. So it is important that you talk to these patients about what is warning signals, how does it work, how to prevent them, how to act on it. So there's a lot of patient education involved. Prompt escalation of therapy, timely outpatient, inpatient visits, monitor labs very closely, and these all can be actually done by something known as remote monitoring. So sometimes I always refer to the adage, to master heart failure, you have to master congestion first. So what is remote heart failure monitoring? It is a system whereby you're engaging, you're informing, you're empowering a patient with comprehensive heart failure management from the safety of their home. This is in the way that so that there's early recognition, there is prompt management, and you're trying to avoid hospitalization. Now, we have some device technologies available, of which, of course, these are devices that we are all aware of. There are some things which are not so frequently available or not really spoken about because of the cost. We're talking about and we are talking about the device such as the CardioMEMS device or the left atrial pressure monitoring device. ICDs and CRTs are easier available in India, but of course not again. It is not so. So we do not really prescribe this offhand for primary prevention, given the fact that they are very expensive devices. Now, why are we really talking about these kind of devices? So we understand that one thing that really goes up when you are having an acute decompensation in heart failure is your filling pressures, which results in increased PA pressures. And remember, by showing this slide to what I'm trying to understand is that generally an index hospitalization is preceded by an increase in PA pressures almost by 2 weeks. So you actually had 2 weeks in time to intervene, but actually these patients come to us by a time where we've already missed the bus. And so, depending on these kind of devices, there have been interventions made remotely, which are very simple interventions, sometimes as simple as just increasing the dose of diuretic or reducing your water intake. And that has actually prevented these patients from hospitalization and has actually reduced costs. So we know for sure from the Champion trial, which was based on the CardioMEMS device, you saw that there was definite reductions in heart failure hospitalizations and all-cause mortality for two reasons. One was because they were better decongested. Number two, they were on appropriate guideline therapy depending on PA pressures. So it's very important that we understand this. Now, the problem in India is that if you look at these are the general devices which is available in the household of a standard Indian. So we are looking at the first four devices. We are talking about the pulse oximeter. You look at the INR costs. Pulse oximeter, roughly any standard pulse oximeter costs about 600, cheap. Digital weighing machine, not very costly. It could be anything between 1.5 to 2K. Blood pressure monitoring is about 3K. Glucose monitoring 12K. Now, the next three devices, something that is not often prescribed but is available in India, and we are talking about the Cardia 6 lead ECG, which a lot of my patients do happen to buy at home, and it's very easy to actually procure an ECG sitting within the precincts of your home. It costs about 18K for the 6 lead device variety, and it's very easy to use. And then you of course have the Apple Watch Series 4 and above, which if I'm sure most of us know it costs in excess of 40K. And remember, it does not work without an Apple iPhone. So you have to both invest in a watch as well as iPhone in order to ensure that you're able to, get an atrial fibrillation detected. The other is of course using the ICD and a CRT with congestion monitoring. And as we know, these are very expensive devices. So, what are our problems with providing such remote monitoring services? We are talking about logistics. We are talking about having data centers, having manpower, having apps, having people like heart failure nurses, trained physiotherapists, dietitians who can remotely monitor such patients. So, we are talking about trained manpower. Then, of course, there's this cost of providing services. We do not know who's going to bear. Finally, it is again ascribed to the patient. Cost of devices, of course, we are talking, as I showed you, both the invasive and the non-invasive ones. So how do we do it in India? And let me show you how we've been monitoring our heart failure patients. So, brief background: a 20-year-old end-stage heart failure, Intermax 4, stays in a Tier 2 city 200 kilometers off Kolkata. Maximally tolerated GDMT, was implanted with an ICD for secondary prevention because she had an out-of-hospital cardiac arrest when she first came into our system. Now she's been listed for a cardiac transplant and happens to be waiting. You see, she's on very, maximal doses tolerable because she does not tolerate full doses of heart failure meds. So she's on losartan half tablet, 25 milligrams, digoxin half tablet, on a torsemide of 10 milligrams, eplerenone of 25 milligrams, a carvedilol of 3.1 to 5 milligrams. And she has also been put on an app which monitors it's a telemonitoring platform for surveillance, nutritional assessment, counseling, and supervised physiotherapy. Now we get a call at 7 a.m. in the morning to the heart failure nurse. There's been rapid heart rate. She's got an ICD shock, sinking feeling. So all that the patient has to do, because she has an implantable device which can basically transmit wirelessly, she opens her app and she just transmits a wireless transmission to us. We open our computers at home, and this is what we get out of our system. So you can see that the patient has got at least 1, 2, 3, 4, 5, 6, 7, 8, 9 episodes of VF with rates which are in excess of 240 to 260. You can also see that there has been one aborted shock, and the shocks that have been given, these are not minor shocks, these are 36 joule shocks. This is a maximum shock that this device can actually give. And these are not ones, sometimes if it's even required two shocks to actually abort this rhythm. And this tells you that this patient is at very high risk of sinking. So what we did is, through our telemonitoring app, is that we asked this patient to call the ambulance service, which can also be hailed from the app. So an ambulance goes out to this patient. She's quickly brought into the hospital, given mag sulfate. She started on Xylocard. She started on Corderone, and we are quick to administer all these, and she's out of danger within 24 hours. So this is something that was not possible unless and until we had these kind of devices. So remember, at 7 a.m. in the morning, there's nobody to go and interrogate her ICD and find out whether the shock was an appropriate one or an inappropriate one. Now, this is a case too. So this was one of my patients who was traveling to the US. She was visiting her son who stays in Washington. She's quite, hypertensive, obese, diabetic. She had rapid palpitations at 1 a.m. in the night. So son reaches out to me on WhatsApp and she said that, okay, this is what happening. So I said, do you have does somebody have a Apple Watch at home? So son says that, yes, I have one. So I said, just strap it onto her wrist and let's see what the ECG says. And this is what it comes out as. So it comes out of atrial fibrillation. And as I remember, she'd also already been had atrial fibrillation in the past, so she had some cordron lying around with her in the house. So we gave her oral cordron, and within some time, within 2 days, she was back on her feet. She was on beta blockers. She was taking her regular anticoagulants. So this is how really remote monitoring helps, because getting some sort of clinical care in the US is generally quite expensive, and it is not covered by insurance often. So last case is this 44-year-old male in ischemic cardiomyopathy, LV function, non-viable LED territory, reports over phone to our heart failure nurse with worsening heart failure, stays about 280 kilometers from Kolkata in a district of Bankura. And he reports an increase. What is significant is he happens to report an increase in body weight of about 2 days by roughly about 1.5 kgs with a one pillow orthopnea. So there's prompt escalation of diuretics with increased fluid restriction, and this patient is again out of danger. So, what are our pains as a cardiologist as far as cardiac monitoring is concerned? So, we are worried about these patients getting readmitted due to lack of adherence. We are talking about low awareness. We are talking about no standard cardiac rehab, diet, exercise plan. And then, of course, these inability to monitor lack of data vitals and diagnostics. So, patients are not coming to the doctor at the right time. So, a lot of our patients stay far away. So, this generally results in costs of hospitalization, which are almost to the tune of 2 lakhs, and it increases costs. So by trying to do this in a remote fashion, there are chances that we are going to reduce the cost burden of heart failure to a great extent. So, what is the future? So, we are talking about connected learning, we are talking about machine learning, we are talking about artificial intelligence. So, all this data, you'll have connected apps, connected devices, which is going to feed data through an app, and you'll have these people sitting in data centers, you'll have patients, trained people. So, you'll have people who are capable of taking impromptu decisions or informing the cardiologist involved so that, immediate treatment which can be administered is done. So my take home would be, so avoid it is very important to avoid a heart failure hospitalization, and that is what is the crux of remote heart failure monitoring. Patient awareness, education, and involvement in treatment is something that's extremely important. Simple interventions like water restriction, salt restriction, weight measurement, compliance to therapy, scheduled OPD visits are likely to cut costs by about a tenth. Of course, we need to use technology like AI, machine learning algorithms, and connected devices to set up warning signs which can pick up early heart failure and treat aggressively and look for precipitating factors. So we intend that this is what was our rickshaw puller with a lot of burden, and this is what it want us to become. Thank you so much, sir.
Thank you, Dr. Kaur, for finishing in time.